Thrombotic disorders. NB. Despite all the recent scientific advances in the identification of genetic risk factors for venous thromboembolism, it is the acquired and clinically accessible risk factors of deep vein thrombosis, DVT, or pulmonary embolism, PE, that still have the greatest impact on risk and decision-making for the great majority of individuals. These include patient age, surgery, malignancy, combined oral contraceptive pill, pregnancy, patient weight, smoking, inactivity, hospital admission, past history of DVT or PE and family history of DVT or PE, irrespective of identifiable genetic thrombophilic abnormalities. Inherited thrombotic disease. Pathophysiology. The clotting cascade activates, and is modulated by, a number of naturally occurring anticoagulants. When protein C is activated, it inhibits factors 5 and 8 with the help of protein S. Antithrombin 3 binds to most activated clotting factors to control their activity and is the mediator of heparin activity. Plasminogen is converted to plasmin when clotting is activated, and plasmin begins to limit the extent of fibrin deposition. Deficiencies of these natural anticoagulants will lead to a prothrombotic or thrombophilic state in the same way as deficiencies of clotting factors lead to hemophilic states. NB. The most frequently identified genetic thrombophilic state is resistance to activated protein C, which leads to a functional protein C abnormality. This results from a mutation of the factor V gene, the Leiden mutation, that renders factor V resistant to the modulating effects of protein C. Many genetic mutations are now recognized in the genes for protein C, protein S, and antithrombin 3, and these cause both quantitative and qualitative abnormalities in these proteins. A prothrombin gene mutation, G20210A, results in overactivity of prothrombin. Hyperhomocysteinemia has become generally accepted as an independent risk factor for arterial thrombosis. Evidence for venous is weaker. It causes abnormalities within vessel endothelium leading to plaque formation. Note that these inherited prothrombotic states manifest in the heterozygous form, i.e. they are partially dominant. Homozygous protein C deficiency is fatal in the neonate. In contrast, homozygosity for factor V Leiden is not fatal but further increases the risk of thromboembolism. Although deficiencies in the fibrinolytic pathway have been intensively investigated, they seem to be clinically irrelevant. Epidemiology. Amongst white patients presenting with their first DVT, 12–20% will be heterozygous for factor V Leiden and 6% heterozygous for prothrombin G20210A. This compares with 6% and 2%, respectively, in the asymptomatic white population. Approximately 9% of patients presenting with their first DVT will be heterozygous for a defect in protein C, protein S, or antithrombin 3. About 12% of the population are homozygous for methylene tetrahydrofolate reductase abnormalities that lead to increased homocysteine levels. It is clear, therefore, that the factor V Leiden and prothrombin mutations are the major players in inherited thrombophilia. It is important to recognize, however, that the majority of people with their first thromboembolism have no demonstrable underlying genetic predisposition and that the majority of people with the factor V Leiden and prothrombin mutations never have a venous thromboembolic event. For the whole population, the major risk factors for venous thromboembolism are not genetic but the acquired risk factors of surgery, malignancy, combined oral contraceptive pill, pregnancy, patient weight, smoking, inactivity, and past history of DVT or PE. Clinical presentation. Inherited thrombophilia usually presents as typical venous thromboembolism, but it is not a major risk factor for arterial disease. However, given that 6% of the population is heterozygous for factor V Leiden, only a minority of these actually develop thromboembolism. Trigger factors are usually required to precipitate the event, e.g. immobility and pregnancy. Unusual sites of venous thromboembolism, e.g. sagittal sinus and mesenteric vein, should result in a search for a thrombophilic tendency. Following a single venous thromboembolic event, patients with inherited thrombophilia should be routinely anticoagulated for the usual time period. There are data that suggest that long-term anticoagulation in this situation reduces the risk of further venous embolism, but this is not normal practice at present unless the initiating event was life-threatening or occurred in the presence of antithrombin 3 deficiency. Indefinite anticoagulation is indicated for recurrent episodes of venous embolism whether thrombophilia tests are positive or negative. The target INR should be 2.5. Asymptomatic individuals who have positive thrombophilia tests but no personal history of venous embolism do not require routine anticoagulation, but vigorous attention to prophylaxis is required during periods of high risk. Pregnancy itself produces a predisposition to venous embolism due to venous pooling, hormonal changes and a natural fall in protein S. This remains the chief cause of maternal mortality. The factor V Leiden mutation occurs in 1/3 of women who have venous thromboembolism on the pill. Screening for thrombophilia prior to commencing the pill is not performed because the detection of factor V Leiden might deprive a large number of women of the potential benefits of these agents. Given that 6% of women are positive for factor V Leiden, a tiny fraction actually develop venous thromboembolism on the pill. The vast majority have no problems. Any personal history of venous thromboembolism is a contraindication to the pill. The use of hormone replacement therapy, HRT, has produced benefits for many women. A personal history of any venous thromboembolism is now considered a relatively strong contraindication to HRT. Positive thrombophilia tests with no personal history of venous thromboembolism are not a contraindication as such, but a strong family history of venous thromboembolism makes HRT hazardous. NB. In what circumstances should someone be tested for thrombophilia? If they have recurrent thromboembolism. If they have a venous thromboembolism before 40 years of age. If they suffer from arterial thrombosis before 30 years of age. If they have thrombosis in an unusual site. If they have relatives who are positive cases. Investigations. NB. Thrombophilia testing should not be performed in the acute phase of venous thromboembolism because this can confuse results. Similarly, testing should not be performed during anticoagulation, except for factor V Leiden and prothrombin gene mutations that are performed on DNA. Most laboratories will perform a thrombophilia screen, which consists of protein C, protein S, antithrombin 3, activated protein C resistance, diluted Russell's Viper test and antiphospholipid antibodies. Genetic testing for factor V Leiden and prothrombin gene mutations may need to be sent to a reference laboratory. Testing for homocysteine levels is becoming more frequent. Treatment. For practical details of how to initiate anticoagulation or to reverse over anticoagulation. Heparin. Low molecular weight, LMW. Heparin has nearly replaced unfractionated heparin for the immediate treatment of DVT and PE. This has been a triumph for a more expensive option that confers quality improvement through the abolition of laboratory testing and multiple subcutaneous or intravenous infusions. LMW heparin enables some patients to be treated in the community. The USA led the way on this because the improvement in quality of anticoagulation which LMW heparin confers over unfractionated heparin has meant a reduction in the number of legal cases based on the premise that further venous thromboembolism was a result of poor control with unfractionated heparin. LMW heparin has superseded the use of unfractionated heparin in pregnancy. Routine monitoring of LMW heparin levels is not required as the majority of patients only receive the drug for short periods of time. However, LMW heparin can accumulate in renal failure. Patients in renal failure treated with LMW heparin should have an anti-XA assay performed after 3-5 days of treatment to monitor for evidence of toxicity. If levels are high, then the dose can be adjusted accordingly. Monitoring of anti-XA levels is also recommended for patients on long-term LMW heparin, such as those taking the drug daily throughout pregnancy. Bleeding is an unusual toxicity of LMW heparin and should be managed by stopping the heparin and giving protamine. Warfarin. Warfarin is familiar to most doctors who realize that serious bleeding complications are the main risk of inadequate control. However, if you read the package insert you will see that there is a multiplicity of idiosyncratic associations. A loading dose type regimen such as Phenerty remains common, but increasingly with elderly patients in chronic atrial fibrillation a gentler approach, commencing with 2-3 mg/day, is being explored. More emphasis is put on treating arterial problems with aspirin rather than warfarin. NB. The main drugs that interfere with warfarin are antibiotics, NSAIDs, and amiodarone.